Hello guys. Hello guys. Can you just give me a thumbs up if I'm visible and audible? Hello guys. So this guys, can you just give me a thumbs up if I'm audible and visible? Yeah. Okay. So this guys, can you just give me a thumbs up if I'm audible and visible? All right. All right. So we'll start with the session. Okay. So we'll start with the session. All right. Any comments? Yeah. Can you just give me a thumbs up? Can you just give me a thumbs up? So I'll start the session now. Yes, guys. Okay. So let me just introduce myself. My name is Dr. Vinish. I'm a senior consultant in anesthesia and critical care. Presently, I'm working with the Rainbow Group of hospitals. From that, there's a hospital called Rosewalk. I'm a senior consultant there here in Delhi. Before that, I was a senior consultant in anesthesia and critical care for 8 years at Fortis Hospital here in Delhi. Before that, I've done my senior residency from Maulana Azad Medical College, and I was also a specialist over there at MAMC, Maulana Azad Medical College here in New Delhi. I've done my DNB secondary from Deen Dayal Upadhyay Government Hospital here in Delhi, and before that DA and FCPS from Grant Medical College, Mumbai. Before that, I have done my respiratory medicine from Sion Hospital or Lokmanya Tilak Medical College, Mumbai. I've also done my hospital administration. Apart from my clinical practice, and I've been teaching students for the last 8 to 10 years, for students who have been preparing for foreign medical graduate entrance exams and the students who are preparing for postgraduate medical entrance exams. So I've been teaching them for the last 8 to 10 years. Okay. I also have a hobby. I play the guitar, and I feel that everyone, all of us, especially in the medical fraternity, should pursue some hobby, whatever it is, listening to music, practicing something. We should have our free time and do something out of it. Now the today's session is a small session that I've thought of, and this session is based on the questions which were set up for the course that I've taken last week. So this was the plus course which I took, local anesthesia and regional anesthesia. After that, I completed anesthesia machine and inhalationals. Remember, this is core concept. It is still available on the plus platform, and I also have a special class which is also available there on the Unacademy platform. Yes, guys, I've also done IV induction drugs and muscle relaxants. I have taken critical care, and in the last I finished airway and intubation, where I discussed all the core concepts. The questions after this today morning were based on all these topics that we have covered, and today was a grand mega test, and after that I'm just discussing the few answers from there which were there in today's exam. So the first question that I'm discussing, propofol vial is discarded after options given: 2 hours, 6 hours, 12 hours, 24 hours. Okay, so remember, propofol, important drug. Okay, propofol is an important IV drug asked many times in exam. All right, propofol is one of the most common used IV anesthetic agents. Again, that's an MCQ question. Now, why is the question of propofol getting discarded? The point is, it's because of the contents of propofol. So this vial of propofol contains egg lecithin, it contains glycerol, and it contains soybean oil. Apart from propofol, these are other contents of the propofol vial. So egg lecithin, glycerol and soybean oil are contents. Now this is a very good culture medium. Because it's a very good culture medium, it can grow E. coli and Pseudomonas. Because it can grow E. coli and Pseudomonas, it can cause infections in the patients. So therefore, I am giving an anesthetic drug, which is the most common drug used, and this drug can cause infections. Alright, that is the reason when you open a vial of propofol, it has to be thrown away. But what's the time? 6 hours. The correct answer is 6 hours. It's not 2 hours, 12 hours or 24 hours. The correct answer is 6 hours, and you throw it because there are chances of infection right up to sepsis. Okay, so these are few points which are important based on the contents of propofol. This question keeps on coming again and again in all the exams, including FMGE. Whether you talk of AIMS or Foreign Medical Graduate Entrance Exam, this question is common everywhere. Okay, let's go to the next one because I want to try it and finish it off fast. It's a short session, so we'll just discuss the answers and the reasons behind them. Okay, now the next one, the doctor on duty. All right, the doctor on duty, this is the question that we had. The doctor on duty asked the technician to get a blue cylinder that has a white shoulder. Okay, so we are talking of a blue cylinder which has a white shoulder. So therefore, what cylinder is the doctor asking for? Options: ethylene, oxygen, helium, Entonox. Okay, so the correct answer here is Entonox. Entonox is the correct answer. As you can see, this question is based on the color of cylinders. Again, a very important question. So therefore, a blue cylinder with white shoulder is Entonox. Okay, so normally what happens, so and what is Entonox? Entonox is a cylinder that contains 50% nitrous oxide and 50% oxygen. As you can see from the diagram also, it contains 50% oxygen and 50% nitrous oxide. Okay, Entonox is a cylinder that contains 50% oxygen and 50% nitrous. Now, the color of an oxygen cylinder is black with white shoulder. The color of a nitrous cylinder is blue, totally blue. So now what you've done is you have a cylinder which has a combination of oxygen and nitrous. So what you did, you combined blue with white shoulder, and this becomes the color of Entonox. So therefore, the Entonox cylinder is blue with white shoulder, which means it's a combination of nitrous oxide and oxygen, and this is what is called as Entonox. Where is it used? Also write down, Entonox is supposed to be the safest anesthetic used. Alright, it's used in labor analgesia very commonly, and also used for dental procedures. Alright, so with that, we finished the second question. If there are any questions, you can ask me, so I'll try to clear them out. So I'm not seeing anything. Okay, let me go forward. Alright, if there are any questions, you can ask me. So next question, which we had set up for the mega test. Alright, let's go there. Least potent of the following inhalational agents. So what I'm doing now is I'm talking about the inhalational agents. Alright, so we are talking about the inhalational agents. So which ones? Desflurane, halothane, isoflurane and methoxyflurane. So desflurane, halothane, isoflurane, methoxyflurane. Now look at four of them. Yes, all four are inhalationals. Nothing is out from there. So basically you have to compare the four of them that we have as an option. The next important question, of course, the question here is which is the least potent out of them. What is the meaning of potency? Potency means which is the least efficient out of them. Alright, which means which is the one which is not strong out of them. So the question asked here is which of the following drug is not strong. So out of the following drugs, the one which is not strong is desflurane. Halothane, very potent agent. Isoflurane, of course it is. Methoxyflurane, MCQ question, is the most potent agent ever made. But in anesthesia, we normally not prefer the most potent agents because most potent agent also means more complications. and we want not to have these complications. That is why it's preferable to use least potent agent, at least which does its function. So desflurane is an agent whose potency is not much but good effect. Therefore nowadays halothane is not used. Of course we use isoflurane, but even methoxyflurane is discarded even for clinical practice. Alright, now how is this property based? The potency of a drug, inhalational drug, I'm not talking of IV drug. IV drug potency is different. It depends as to how the drug enters the cell. So we are not talking of that. Inhalational drug potency depends on a property that is called as minimum alveolar concentration, MAC. This is minimum alveolar concentration. Okay. Also, the potency of a drug is inversely proportional to minimum alveolar concentration. So therefore, nitrous oxide has 105% as the minimum alveolar concentration. It's the least potent drug. Methoxyflurane, it has 0.16% minimum alveolar concentration. It's the most potent. Desflurane has 6% minimum alveolar concentration as its value. Alright. So therefore, it is the next second after nitrous oxide. It's the second least potent agent. So that is what was asked in the here in the question. So basically the question was based on the concept of minimum alveolar concentration. You are supposed to know what is minimum alveolar concentration and what is its relation to potency. So minimum alveolar concentration is inversely proportional to potency as to how the strong the drug is. So less the value, more potent the drug, more the value, less potent the drug. Desflurane has 6% value, so it is less potent. Let's go forward. So we'll go to the next question. Alright, next question. Most common mode of neuromuscular monitor used to monitor the action of pancuronium. Single twitch, double burst, train of 4, post technique stimulation. This is a normal first year MBBS question that comes from physiology. It's a common question between physio, pharmac and anesthesia. Okay, neuromuscular monitor. Now the point is they are just asking what are the modes of stimulation that we use. So in physiology we see there's a single twitch where you give a single stimulation to a muscle, double burst is 2 stimuli, train of 4 is 4 stimuli, and post technique stimulation is after the tetany has taken place, you then give a stimulation. So this is action of various stimuli on muscle which we study in physiology. Here simple question, the most common mode of neuromuscular monitor used is train of 4. Okay, simple question. Clinically speaking, we use train of 4. Train of 4 is the one which is the most common used. Okay, so no questions. I have not got any questions till now. Had they been, I'm not able to see actually. If there was any question, I would have taken them. Okay, so let's go forward. So let me finish off the the way the quiz was set up and discuss the questions related to that. Which one of the following sequence is correct regarding the nerve function recovery once you have given local anesthesia drugs? So it's not asking as to the order as to how they are going, but what happens during the recovery. Which function will recover first, which function will recover later. Options given are 4: sensory, motor, autonomic, autonomic, motor, sensory, sensory, autonomic, motor, motor, sensory, autonomic, simple. These are the type of questions which are asked whether it is AIMS, whether it is FMG exam or NEET PG or any exam that you take in PG entrance. Okay, very common question. One below, one above the other, which one is better, which one is later, comparison of them. So simple. Here you need to know that what is the order of block. The order of block normally is autonomic first when it gets blocked, then what gets blocked is sensory, after that what gets blocked is motor. So therefore during recovery it will be opposite. Opposite is what? First motor, then sensory, then autonomic. So the correct answer is D. The other three are just given to confuse and waste time. Simple. So if you know the order of blockage, which is autonomic, sensory and motor, the reverse takes place during recovery, which is motor, sensory and autonomic. So therefore you find when you've given a spinal and after the spinal, when patient recovers, so you will find for example, a patient was undergoing lower segment cesarean section. When we give spinal, patients' legs become heavy, they can't move. But when the surgery gets over after 2 hours, they are able to move to the trolley. Why? Because the motor function is recovered. and they are able to move to the trolley without pain. Why? Because sensory effect is still working. This is what gives the post-operative analgesia. Therefore, whenever you give regional block, whenever you give spinal anesthesia, therefore what happens, even if the motor block goes away, at least patient has sensory block which takes place of sensation, because of which pain relief is there, because of which patient gets post-operative analgesia. And that is why you will also find, wherever preferable, people use regional anesthesia over general anesthesia. For example, all of us know appendicectomy, appendix surgery, is supposed to be done under GA according to books. But most of us, when we work in medical colleges, government hospitals, we get it done under spinal anesthesia, because spinal and regional is considered to be better where possible, and that is the reason we do it. It offers safety plus post-operative analgesia also. So let's take the next question. The spread of spinal anesthetic solution is not affected by, okay, so position of the patient, weight of the patient, anatomy of spine, height of spine. So basically what happens is, when you are giving spinal drug, if this is the patient, all right, when we are giving spinal drug, this is the patient, so the drug goes here inside the CSF, all right, and it creates a block. That is what is called height of block. Height of block means below that everything is gone, so surgery can take place below that height of block. Now the position of a patient does make a difference. If the patient is lying down, then what will happen? You give a block, the drug can spread. Okay. If the patient is sitting, the drug tends to be below. So therefore, position of a patient does make a difference. Anatomy of the spine, we all know kyphosis, scoliosis, the spine becomes twisted, spine is turned. So you don't know where the CSF is, you don't know where the drug is gone. So again, anatomy does make a difference. Height of the patient. Now someone who is tall, simple, if we just use our mind and think of a tall patient and a short patient. So if both of them have to get a surgery, a long patient will need more drug, a short patient will need less drug. Simple. So height also makes a difference. The only thing that does not make a difference is weight of the patient. But remember, here the correct answer is weight of the patient. In case they have given obesity, remember obesity does make a difference. Okay, so normally weight of the patient does not matter, but if there is obesity will make a difference. Apart from that, the position of the patient, the anatomy of the spine, and height of the patient, they are important factors. Here weight of the factor is not important. This is not going to help the spread or decrease the spread of the anesthetic solution in the spine. All right, let's take the next question. Pre-oxygenation increases which of the following parameters? So even if we don't know the options, first you should read the question. The point is, pre-oxygenation means you are going to give oxygen. Pre means before something, okay? So therefore the point is, pre-oxygenation will increase which of the following parameters? Options: tidal volume, inspirated reserve volume, functional residual capacity, and vital capacity. Again, this is a common question, basically a physiology first MBBS question, all right, combined with anesthesia. That's how question comes in exam. All right, so basically pre-oxygenation is a thing which is done before we intubate someone, before GA. So before intubation, before giving general anesthesia, we pre-oxygenate the person. What is pre-oxygenation? Holding a mask and give oxygen for 3 to 5 minutes. So what will happen? Because you are holding a mask and giving continuous 100% oxygen to the patient. See, if you know, we are breathing room air. Room air contains 21% oxygen, 78% nitrogen. Okay. So if you are holding a mask and giving 100% oxygen, all this 78% nitrogen gets replaced by oxygen, and this is called denitrogenation. MCQ question. So what is denitrogenation? Same thing as pre-oxygenation. I am giving oxygen so that it replaces nitrogen, thereby increasing oxygen stores in the body. Thereby, if I will take time to intubate, at least patient will not die. He will not die of hypoxia, he will not desaturate, and that is the importance of pre-oxygenation. So therefore, out of these 4 parameters, what is the parameter which increases? As in, where is the oxygen store increases? Where? So let me just delete it out. Tidal volume is this is spirometry now. Okay, so tidal volume, inspiratory reserve volume, expiratory reserve volume, and vital capacity. Same spirometry graph which we normally see. So FRC is the residual volume. All right. The last part that you see, this is what is called functional residual capacity. The correct answer here is FRC. Whenever you study medicine, you will find people always saying, you know, FRC, FRC, FRC. Why? Because FRC is the most important component of spirometry. Tidal volume is the normal breathing, inhalation, exhalation. Inspiratory reserve volume is the extra volume when we take a deep breath and we are inhaling. Expiratory reserve volume is the one which is in the end when we leave it out completely, and the last which is left is residual volume. This is physiology. So tidal volume, inspiratory reserve volume, expiratory reserve volume, and residual volume. So functional residual capacity is a combination of the reserve of the body. Important MCQ question, because it is the reserve, you are increasing oxygen in the reserve of the body, which is the residual volume. So you are increasing the reserve, and that is why pre-oxygenation increases FRC. Okay, so we are done with the next question. We go to the next one. So I'm taking it fast so that I can try to cover as many of them. You know, it's a short session that we have. The following may be used for weaning a patients, okay, from mechanical ventilation. Now we have come to ventilator, ICU, critical care. Okay, so what of the following modes can be used for weaning? A very common question, TPs, synchronized intermittent mandatory ventilation, pressure support ventilation, and volume controlled ventilation. Okay, I actually can't see any questions, you know. All right, I thought if I can get answers, then I can include that also over here. But anyways, let me go forward. So TPs, synchronized intermittent mandatory ventilation, all right, pressure support ventilation, and volume control. So remember, weaning off means what? Weaning off means you are trying to take the patient off from the ventilator. That means you are trying, this patient has got better. He does not need ventilator. Okay, he does not need ventilator anymore for support. He does not need ventilator for breath. First thing, volume controlled ventilation means you are controlling the volume. Simple. So this is control mode where you are controlling the volume. TPs is a normal spontaneous mode where you are breathing. SIMV is synchronized intermittent mandatory ventilation, and this is pressure support. So anyways, this is support mode. So TPs, SIMV, and pressure support, these three are used for weaning. They are all. And because this is a controlled mode of ventilation, this is not used for weaning. Ideally, I would have loved to go into the whole topic and teach the whole thing, you know, control ventilation, support ventilation, but you know, we have to discuss more questions. So basically, you know, there are two types of ventilation, control and support. Control means where I control the patient's breath. Support is where he can breathe on his own. So therefore, in TPs, patient breathes on his own. SIMV, patient tries to breathe on his own. Pressure support, patient is breathing on his own. In volume control, I am giving the breath. No, the machine is giving the breath. Okay, but I am controlling the breath of the patient. So that is why volume controlled ventilation is not used for weaning. Apart from that, the other three can be used. Okay, they are support modes. Next question. Which